of the internet a very similar CT scan. So there was a 6 centimeter mass in the head of her pancreas, which appeared on her scan contained within the pancreatic head. It was hypodense on CT, as this one is. And there was concern for maybe being a cyst, maybe being a solid lesion. And the pancreas appeared otherwise normal. There was no dilation of the pancreatic duct. There was no biliary obstruction.
Do you have a sense, Mark, that
So
in
this
this
seemed
patient, what was it in the what part of the pancreas was it in?
it was in the head.
Okay, that's interesting.
Yeah, which maybe is not the most typical location for this, but that's where her
Mhm.
lesion was. 6 centimeters, well demarcated, hypodense, and contained within the pancreas. And so she had an endoscopic ultrasound. And for those of you who aren't familiar with at the Korean hospital, so this is the transducer of the ultrasound unit on the tip of the endoscope. The shaft of the endoscope would go back along here. You don't actually see it, but this is where the shaft would be. So the endoscope has been passed through the pylorus into the duodenal bulb. And this is actually the wall of the duodenal bulb from there to there. And we see the mucosal and submucosal layers and the muscularis propria. But what we're really focused on is this 6 centimeter lesion here in the pancreas head, which is sort of heterogeneous and lobulated, some areas darker than others, and with some flow, but within it on Doppler. And so we tried to get some core biopsies of this lesion. We only had a needle for taking aspirates, but I think it was Marie who taught me that for this suspected lesion, we really want a biopsy. So we tried our aspirate needle to get, if we could, some microscopic cores of tissue, and Marie will take us through the specimens. So Marie, I've got several slides here. This one, and this one, all from
Yeah.
Taye. And so you tell me which ones you want to start with.
Yeah. Well, let's start. Start with this one here is fine to start with, and you got an incredible sample actually, so this is a very generous sample of a lesion in the pancreas that raises just from my eyes things and towards a couple other things that we would then we would be applying immunohistochemical stains to help prove our point, and that may or may not be available and probably is not necessary here because we have such a demographic of a young woman. So let me just go back to the histology here. We're staring at, so all the red stuff in the background is blood that comes out with the aspirate. We can ignore that. But all the purple and blue regions are clusters of clinging to each other. And that sort of clinging together of cells forming groups, tight groups like that, is very typical of epithelial type of neoplasms. Whether, and even neuroendocrine, for example, are a type of epithelial neoplasm as opposed to sarcoma, for example. See, let's look at the next slide. You can see here, sort of in the middle, but a little bit high. There's right there. There's a rounded structure of cells with maybe a little vessel. There's a little red blood cell, a little tiny space in the middle, in the center of it. So we would call this sort of a rosetting, a rosetting structure, and this is of a suit. So very fancy pathology speak, and I don't even, I think when you look at this, when I think of a full papillae, something that's sort of villiform and a frond-like, that's not what I see here. Yet we know in a particular type of tumor of the pancreas, as cells sort of fall apart and away, they give this rosetting form. What I'm not seeing here is classic glands of, let's say, adenocarcinoma of the pancreas, pancreatic ductal adenocarcinoma. Instead, and let's look at the next slide. I think there's one more. Yes. This is sort of a higher magnification. All these purple dots are the nuclei of a tumor, this tumor. And what you can see here, if you're a pathologist, is notice that they are fairly uniform, the same shape and size, most of them. There's not a lot of what we call pleomorphism or differing sizes, and that is not typical of an adenocarcinoma, so we can put adenocarcinoma aside. The other thing about it that is against adenocarcinoma is that there are very small nuclei, not large ones, and there's a whole bunch of cytoplasm. So the paler pink areas around these purple nuclei is the whole cell. And there's really quite a lot of pink cytoplasm. In addition, I don't see mitotic activity, which would have these very distinct purple sticks within the nucleus of the chromatin lining up. And then finally, here and there are some, they're a little bit hard to see, but there are some nuclear grooves, meaning there's this little straight line inside some of the nuclei. And that's actually sort of characteristic of this lesion. So I've said I don't think it's adenocarcinoma, and I've given you very lightly some reasons why. But that doesn't give us the diagnosis, because there are other tumors. There's acinar cell tumors. There are neuroendocrine tumors, which are probably the next most common tumor after an adenocarcinoma. And then there's an entity called solid pseudopapillary tumor of neoplasm of the pancreas. And we are going to land there, and I'll get to why. But one would need to, looking at this field here, one would certainly suspect that this could be a solid pseudopapillary, but one would, in our house, we would be doing stains to exclude acinar cell and neuroendocrine tumors, even though some of those stains overlap, like synaptophysin. But suffice it to say that a young woman, even though this is in the head, whereas normally these are in the body tail, this has all the histologic features that are perfect for solid pseudopapillary neoplasm of the pancreas. And I think, Mark, are you going to talk about what that tumor is a little bit? And I can stop here. Okay, so I will stop here. It's a great sample.
Yeah, thank you. And maybe I'll just ask Taye, who originally interpreted the specimen, do you want to comment on this case, on the histology? You're muted still, Taye. Thank you.
So, actually, histologically, beside the location of the tumor, I also convinced of the diagnosis of pseudopapillary tumor, as already mentioned. But the other thing I want to add is, after she left to India, they did immunohistochemistry in India, and the immunohistochemistry results were also highly suggestive of pseudopapillary tumor, with the beta-catenin positive, ecadrin negative, SOX stain also positive. So the immunohistochemistry, some of them we have it in our country, but some of the immunohistochemistry we don't have it. So I already communicated, before I signed out this case, I communicated with the gastroenterologist, and we discussed the case. But solely histologically, it's typical feature, but it needs immunohistochemistry confirmation. So after surgery, they did also immunohistochemistry confirmation at India.
That's great follow-up. Yeah, you did an excellent job.
Okay.
So just for the rest of us on the call to review, what is this solid pseudopapillary neoplasm? So this is a pancreatic malignancy. It is often low grade, but it can be aggressive, it can be metastatic, and it typically presents in young women. So that when we saw this 17-year-old with a pancreas head mass, we suspected even clinically that this might be the diagnosis. And we've already heard about immunohistochemistry. Maybe, Marie, you can comment a bit more on that. I thought a lot of these tumors had progesterone receptors in them, but Is that old information, or because the stains Taya mentioned were something else?
Yeah, no, they do, and that's actually not specific. So the other one with progesterone is a microcystic serous cystadenoma. Of course, that would never be confused with this. But there's actually this laundry list of immunostains. What is what is I think most performed is beta-catenin, which shows like 98% of these in aberrant nuclear expression. You can have loss of E-cadherin, which is just a membranous marker in many epithelial cells, and a host of others. Notably, in addition to progesterone receptor, which I'm reading here is positive in about 63% of cases, neuroendocrine markers, especially synaptophysin, are positive, as well as keratins in these tumors. And that gets to the fact that the origin of these tumors, it's not from a classic mature cell type we think of, like a ductal cell or an acinar cell or a neuroendocrine islet cell. It's from some sort, they don't really know, it's unclear, from some sort of stem cell in a rest, maybe of embryologically deposited in the pancreas. So therefore it expresses on immunohistochemistry a variety of markers of other tumors.
Thank you. So these are some from the internet, some pictures of the growth of some of these tumors. And I'm struck by how lobulated it can look, just as our lesion did on ultrasound, and also well encapsulated in appearance. And here's data about survival after resection. This study, fairly recent. And you can see that the overall survival after resection in this series and also in other series is actually quite good. It's much, at least for pancreatic neoplasms, it's much better than adenocarcinoma, for instance. So in this series, overall survival of about 75%, and recurrence-free survival of 85%. So most patients with this lesion, even though 6-centimeter malignancy of the pancreas head, the prognosis is actually reasonably good with surgical resection. And Taye, she did have a surgical resection. You got some follow-up about that?
Yes, as I told you, already they did immunohistochemistry. Also, on the surgical staging, TNM staging was T3 and 0. But I couldn't get detailed report, only the staging and the diagnosis and some of the immunohistochemistry results. Yes.
All right. Well, thank you.
Okay.
All right. So on to case 3. This is a 60-year-old woman who had 1 year of abdominal pain, really marked weight loss, and occasional vomiting. She had anorexia, but she had no fever, no sweats, no jaundice. On physical exam, her BMI was 15. She had some mild epigastric tenderness, no other exam findings. And strikingly, her labs were normal. Her CBC was normal, her routine chemistries were normal, her serum liver tests were normal, and tumor markers, CEA, CA19-9, they were all normal. And she had a CT scan, which I'm going to show you several images from. There was a mass in her pancreas in sort of the neck of the pancreas, and it's this hypodense area here, just impinging on the pancreas duct, which is going to be over here. This, by the way, is the stomach. And then her gallbladder was distended as well. And on this cut, there's actually this mass here next to the gallbladder. And the radiologist was a little unsure, was this arising from the gallbladder or just another lesion in the porta hepatis? The tumor is here in the pancreas neck, just the very edge of it, you've seen on this slice. And this is the pancreas duct, which is dilated in the upstream pancreatic tail. And you'll have to take my word for it, it was normal, the duct in the head. And here again is this picture of this something maybe arising from the gallbladder, maybe not, but in the porta hepatis with some sort of rim enhancement. The IV contrast is enhancing the rim of it more than the center. So she also had an endoscopic ultrasound, and this is the view of the thing next to the gallbladder. So here the scope is in the duodenal bulb again, and we're imaging facing superiorly from the duodenal bulb. And this is the gallbladder neck, this anechoic dark structure. This is portal vein over here, and hepatic artery is the smaller structure with Doppler signal in it. And this is the lesion in between, adjacent to the gallbladder. And there were actually several things here that looked like very large malignant appearing lymph nodes. So we took aspirates from there. And then this is the mass in the pancreas neck. So the scope is in the stomach. Here's the stomach wall. And you can see we're just right next to this thing, which is heterogeneous, has the edge is not as well defined as that solid pseudopapillary tumor we looked at in the last case. This is the splenic vein back here coming from the spleen, which would be off to your right on this image. And the splenic vein was compressed by this lesion. This is the splenic artery. And there was the pancreas duct upstream from here. Oh, I don't have a picture of it, but the pancreas duct upstream from here was dilated. And in fact, the pancreas duct was kind of in the way for taking a biopsy of this. The needle would come from here and go right through into here, and the pancreas duct was almost in the plane. So instead of biopsying this lesion, we also biopsied a very large malignant appearing node that was right next to this mass. So we sent to Taye aspirates of 2 lymph nodes. And Marie, I'll just go quickly here. These are the slides, the images as Taye sent them to me, and I'm not sure that they fully represent everything. He told me that the cytology slides had degraded rather badly by the time I asked him for these photos. But maybe tell us what you think.
Well, I actually think they are very useful. And if we go back a couple. Is this the first slide?
Yeah, 1, 2,
Okay.
3.
Yeah. Yes. So let's go back one. And this one, yes, it's the higher mag. So, and again, it's a very good sample. And what we're seeing here is something that we do not get that frequently in our region, not to this degree and diagnosed in this location. But what we're looking at here is necrotic tissue. And while and then there are some purple dots that are mostly lymphocytes, as far as I could tell. I'm sure there are many macrophages in here as well, the paler cells. And so, and if you go to the next slide, and this is a higher magnification of all these purple dots are the cellular component of this aspirate. These are all inflammatory cells. So there's nothing in here that is, now I realize this is of a lymph node, right? It's not the pancreas itself. Peripancreatic and pericholecystic lymph nodes. So we are expecting lymphocytes in lymph nodes, so that is fine. But there's this background of necrosis that it just is screaming out infection as the number one thing. That would be the number one thing. I don't see well-formed granulomata, which would be hard to see in an aspirate in any case. But and this so it's not, to me, this is not specific for the entity that I think you ended up diagnosing. I would need to do stains, or even we have a PCR for, I'd be doing stains for fungi, to TB and bacteria. If this were my sample, to try and see, okay, can I identify an organism? Otherwise, things that are necrosis near the pancreas, of course, are pancreatitis with pseudocyst formation. It doesn't seem to be quite fitting what you saw. But so necrosis by itself is not specific, but this, in all the nodes and in this kind of setting, I would want to say, fortunately, we don't see evidence of a malignancy, not even a lymphoma. This looks very mixed, but pointing towards rule out infection as the top 10 diagnoses. And I'll stop there, because I think I would be lying if I said I can make the diagnosis that this ultimately turned out to be. I can suspect it. I can suspect tuberculosis very strongly with this kind of, almost caseating necrosis, but I don't have all the features to point there.
Thank you. Thank you, Marie. Taye, do you want to comment on this case?
Yes, Professor. I think in this case, what we find there was two preparation. One is a cell block biopsy. We did the centrifuge of the specimen and we do it as cell block cytology. There were also another slide which were smeared and evaluated by PAP and right stain. So what we see is most of the slides are from the cell block cytology. So from the cell block cytology, what I found was as already said, there is necrosis and the inflammatory cells, which can rule out, which cannot suggest any, which can rule out any lymphoma or any other cause of malignancy. But on the cytology, I found some vague granuloma. Unfortunately, I couldn't capture the picture because of the condition of the slide. But I found a few vague epithelioid granuloma at one area. And this is also, I think, in our country, it's very common to have tuberculosis everywhere. So again, it's difficult to diagnose tuberculosis with this slide, but considering those epithelioid aggregates and cases like necrosis, and also clinical correlation. Again, this also discussed with the gastroenterologist. With clinical correlation, I decided to cite as caseous necrosis, which is suggestive of TB. Unfortunately, we didn't do also FEB or PCR here. FEB actually we can do it, but at that time it was not available. PCR, we cannot do it here. So the only option I have is to sign it out by those histologic finding with the clinical correlation of
I'm sure you're right and did a great job with that. If there was an AFB stain on this, I would be hopeful that there would be quite a number of organisms, and that would be fun to see, but not necessary. As you say, you've really got many things to go on. So thank you.
Okay. So Taye's advice to us as the clinicians was really key because we thought this was cancer. We thought this was a pancreatic cancer metastatic to nodes. And so his suggestion, he said, suggestive of TB. Here's one more slide, but here's what he wrote in his report, which is indeed what's already been discussed. And so we started this patient empirically on standard anti-TB therapy following national guidelines. That was now almost 4 months ago. All her symptoms have resolved. She's gaining weight. And we think that this really supports the diagnosis of TB, which, as Taye said, is very common in our setting, although not in the pancreas. And she will have follow-up CT scan after she's completed her TB therapy, so in another couple of months. And just a brief review about pancreatic tuberculosis. So this is a rare diagnosis. Its clinical presentation often mimics pancreatic adenocarcinoma. And on imaging, it can present as a solid or a complex cystic pancreatic lesion. There's also reports of it presenting just as diffuse pancreatic enlargement. So it could really mimic cancer, a complex cystic lesion, or maybe even autoimmune pancreatitis. And you know, I know, speaking to those of you, at least who are in Ethiopia, you're going to wonder, should every patient with a pancreatic mass now be put on TB therapy? And I would say no. Most of them have cancer. But there were clues in this case, looking back, that maybe this wasn't a cancer. And the first one is that she had normal serum tumor markers, which is not common in pancreatic adenocarcinoma. And the other is that she had those peripherally enhancing lymph nodes, the ones in the porta hepatis. And that really speaks to central necrosis of a lymph node. So that's this here. The rim of the lymph node is enhancing, the center is dark. And that sort of enhancement pattern on a contrast-enhanced CT would be suggestive also, at least in retrospect, of TB. All right, I think we're going to move on to case 4 here, and it's good because we're going to run out of time after 4 cases. So this is a 71-year-old female who had 1 month of jaundice, pruritus, and acolic stools. She had comorbidities, including hypertension, diabetes, and obesity. And physical exams, she had jaundice and skin excoriations. Her total serum bilirubin was 32 milligrams per deciliter. normal being about 2.5 milligrams per deciliter, alkaline phosphatase 560, transaminases almost normal. Ultrasound showed dilated intrahepatic bile ducts, dilated common hepatic duct, common bile duct not well seen. And this is a slice from her CT scan. Here is the liver over on your left. A bit of the gallbladder is shown here. This is the stomach. Here's the aorta with the celiac trunk coming off. This is a bit of portal vein here, this whitish structure. And this is the bile duct right here in the center of the image. Maybe I should have given a blown up image, but this is where her lesion is. So I'm not showing you the dilated ducts part of this, but the area where there's a bit of a thickened, enhancing bile duct wall. No obvious extension of anything from this location. So she had an ERCP at the Korean hospital, and these are images from that study. So this endoscope is here in the C loop of the duodenum, and a catheter has been put in the major papilla. This is the distal bile duct in the pancreas head. It looks pretty normal. And then there's a stenosis going behind the endoscope here where you don't see the bile duct. You just have these white areas. And then the bile duct proximal to the stenosis is dilated. This is a guide wire going up the bile duct. And then this image on the right is similar. We filled more of the intrahepatic ducts now with contrast. The stricture still is behind the endoscope. And we've put a biopsy forceps into the papilla and up and opened the jaws. You may be able to see the jaws here. And we're taking intraductal biopsies of this stenosis to try and get a histologic diagnosis. And we will review those biopsy results now. So Dr. Robert, these are the slides. This one, this one, this one, and that's a different case. So I have 3 images.
Okay.
From
and again, it's a very good sample. We miss your samples at Yale, Mark. You always get very good samples.
Well, here, especially for this sort of situation, we don't have another way to make a diagnosis besides intraductal biopsies. So we use a standard forceps, and we take at least 4 biopsies because we know we're not going to have brush cytology. The brushes are too expensive. And so forth. So go ahead.
Well, it's always very satisfying. So this is an example of a diagnostic, a fully diagnostic biopsy of a biliary stricture. And I'm making this point because we get a lot of these in our system. We have a very robust pancreatic biliary GI service at Yale, and yet. Many times, even with brushes and biopsies, they're often smaller than this, the biopsies, and we are not able to make a diagnosis, and yet we're still worried about it. So patients, they're followed. Like we're not hoping to make malignant diagnoses, but yet we always worry when there's a stricture and we have a very, very small sample. We can't help but wonder, is this tissue representative of the lesion? So at least this patient can be treated. So what are we looking at here? So in the bottom left, there's a curved structure lined by epithelium, and that's the surface, a little bit higher. Yeah, right there, exactly. So we've got the space is the lumen, and that is some surface epithelium. And then going, north and towards the right is the tissue underneath the surface. And in that tissue, there are a bunch of purple dots, those sort of big purple dots of nuclei. And let's look at those at higher magnification. And I think, yes. And so I want to point out 2 things. One is that the brightest and darkest purple dots are enlarged nuclei, and they have a cytoplasm around them, and some of them are nested and cohesive clusters, meaning they have features of epithelial cells, not stromal cells. So when you're in the deeper mucosa, you're expecting fibroblasts and some neural tissue, vessels, but not epithelium. So we already have epithelium where it doesn't belong. And that's can be some benign deep glands, but when they're atypical like this with an infiltrative, they're sort of here, there, and everywhere, not in a nice lobulated form. That is an adenocarcinoma pattern. Further, the stroma, the paler pink around all of these darker purple cells, is fibrotic. It's got extra collagen laid down. It's not the loose areolar sort of tissues of the lamina propria and submucosa of the bile duct. So we call that a desmoplastic fibrous response. And so we have here really all we need to make an unfortunate diagnosis of adenocarcinoma in this patient. And I think the next slide shows a similar, I don't know if there's one more or not. This is even a higher magnification. So you can see very enlarged nuclei compared to, we have some pale nuclei in the background of the fibroblasts, and these are really, really double, triple size, and they're cohesive, sticking together, and lots of cytoplasm. That's what makes them epithelial.
Thank you. Taya, you want to comment on this case as well, which you provided for us?
I have no comment here.
Okay. So
did I get it right, Taye?
Yes, exactly.
Yeah, Taye signed this one out for us as adenocarcinoma. I mean, there was no, it was a definite, and I'm going to come back to these slides, which are a different case, and just give you the follow-up about this patient. So during that procedure, we also placed a biliary stent, a plastic stent. Her serum bilirubin normalized, and she went to see a hepatobiliary surgeon because it appeared that her lesion was resectable. And unfortunately, she is not having resection. It was felt that her comorbidities were too great, and at her age that she might not do well with surgery. So she is receiving chemotherapy for her tumor, and we will change the plastic stent to a metal stent here at some point. So diagnosis of cholangiocarcinoma for our audience can be challenging because their percutaneous ultrasound-guided biopsy of something like this thickened bile duct wall is really problematic. And so in our setting, we're using biliary intraductal biopsies quite a bit, as in this case, and they are safe and cost-effective. The sensitivity in the literature, you can see there, 50 to 65% for adenocarcinoma with a specificity of well over 90%. You can also do chromosomal analysis of cytology specimens collected with a cytology brush from the stricture. And that's called FISH, fluorescent in situ hybridization. And that is used to find chromosomal changes in the tissue, such as aneuploidy, that could be diagnostic of malignancy. And that has similar sensitivity and specificity to biopsy. As I said, in our case, in our setting, we don't have that. We can't afford the brushes, which are single use. And it will also require some pretty fancy pathology lab equipment, I believe. Serum CA-199 levels can be used, but they can be elevated in biliary obstruction of any cause. If they're very high, over 1,000, that's pretty specific for malignancy, and CEA is not that sensitive or specific. So we really rely on these biopsies. And we also rely clinically on the bismuth stage of the tumor to guide treatment. And bismuth 1 is a hilar cholangiocarcinoma where the right and left hepatic ducts still communicate with each other. So one stent would drain the bile from the entire liver, and the surgeon also would have a relatively easy time resecting this tumor with a clean margin. Bismuth 2, the right and left ducts have been separated from each other by the tumor. So to get the jaundice to resolve, you have to drain at least half of a normal liver. So you would have to put a stent either to the left and the right, or just to the right. And the surgeon will have, this is more challenging for the surgeon to resect, at least to do an R0 resection. Type 3A, the tumor spread up to the first branch point of the right duct, separating the right anterior and posterior ducts. And this patient, if they're going to have surgery, is going to be a right hepatectomy, sometimes an extended right hepatectomy. Bismuth 3B is the same sort of situation, but on the left. It's extended here to the junction of a segment 4 duct with the segment 2 and 3 ducts. And this patient is going to have a left or extended left hepatectomy. And bismuth 4, it's extended well up on both sides. And this is very problematic, either to drain endoscopically, percutaneously, enough to get the bilirubin to go down, or to have surgery. This patient, in some settings, if it's localized disease, would have actually chemotherapy and radiation followed by liver transplant. So sort of a summary of the biliary staging of these tumors. So I want to see if I can go back now. And Taya gave me this other case, Marie, and I think this is a case that, if I'm correct, Taya, you did not sign out as a definite diagnosis, and I think the pathologists on the call are very interested in what you think about this case. This is another case of intraductal biliary biopsies of a stricture.
Okay. Yeah, so I just glanced at these this morning very quickly. And so are you in is this the common hepatic duct or the bile duct, or what?
Yeah, common hepatic duct.
Common hepatic duct. Okay, and there's a stricture. So again, fantastic biopsies, really generous. And so we're at this magnification. Again, there's a lot of busyness in the stroma. I don't quite see all the surface in this picture, which is absolutely fine. Within the wall of the bile duct, it appears to be fibrosis. And then again, a lot of these purple clusters, some of them individual, some of them together, that I think look epithelial. And while we do get submucous glands and invaginations of epithelium, those should be sort of lobulated and rounded structures. So I was suspicious at this magnification that we had a lot of also single cells and an infiltrative pattern. But let's look at the next slide. So a higher magnification, and to me there are several cell types here. One is in the background. There's bland fibroblasts or myofibroblasts with these elongated nuclei laying down collagen. So they're reacting, and it could be a cancer, it could be an inflammatory process. They react to anything. And then there are some neutrophils percolating around, and inflammatory cells with small nuclei percolating around in the background here. But then there are, again, these big purple blobs of nuclei, many with irregular shapes that have some decent cytoplasm, and some of them are showing cohesion, clinging to each other, and some of them appear to be single cells. And I really can't get away from adenocarcinoma in this so far. And I think there's another slide or two. So again, yeah, this is good. So when looking at this, and you're trying to sort this out, how far can you go? Can I make a diagnosis? The question I ask myself is, what else could these cells be? So if you look sort of in the center, there's 3 or 4 single cells with very large nuclei, irregular nuclear contours, and some degree of cytoplasm. So I do not believe that these are fibroblasts. I think the nuclei are too large and hyperchromatic. These are not lymphocytes or macrophages. The nuclei, again, are too big, and it's got too much cytoplasm for a lymphoid cell. And then I'm really left just not part of a blood vessel. It's not part of a nerve structure. And so I'm really out of options here. And for me, if I really had doubt, I could do a keratin stain that may or may not be available. But I believe that this is adenocarcinoma. And it's in some ways, it's a little bit reminiscent of the case that we had just looked at. But I'm curious, Taye, you've stared at this, you've had the whole case in front of you. What are your thoughts?
Yes, I also think of epithelial magnets like adenocarcinoma, because some of the cells are forming poor granular structure in some area. Mm-hmm. And also I can see some polymorphism there. There is also significant, the problem I have with this case was there was a significant crushing artifact. Yeah. So I couldn't really appreciate the cellular detail. over the cell, but I have no option other than to calling it at least suspicious for adenocarcinoma. But it's a very challenging case for me, to speak frankly.
Yeah. And these are, let's look at, is there one more picture or did we skip one, or is that? Can't remember if we looked at all of them. Yeah, this
is
is particularly challenging because this has got a lot of crush artifact and there's inflammation as well. So yeah, I think you're in good stead to consider this an adenocarcinoma.
Well, and at least for a gastroenterologist reading your pathology literature, when you say suspicious, it's almost always cancer. You can correct me if I'm simplifying too much.
Well, I think that's right. In this case, I believe at Yale, we would probably call it outright adenocarcinoma because of the amount of material there. But I am not the one with all the slides in hand and the patient in front of me. So I suspect there are some tricky parts of this that I may not be fully appreciating. I think the busyness of it with this overlay of inflammation can make it challenging. But I don't really have any other way to explain these markedly enlarged nuclei with epithelial features. And do you
Marie,
have? Oh, go ahead.
What can we do as a clinician taking a biopsy to avoid crush artifact? Do you, if anything, what's your advice about that?
Yes.
I think you all do a pretty good job. I'm not sure with the forceps you can avoid, I don't think it can be avoided. What it happens is in some tumors more than others. There's this to me is not too much. We've got plenty of fields where there is not any crush artifact. So I think this is perfect. There's no crush artifact here. And I think what we do like is this, and this happens in the colon more. When big polyps are removed, often there's cautery used at the time, and that can really be impossible for us. If there turns out to be a cancer in the polyp that was unsuspected in the head, then we're stuck with that margin base. So that's when we're sort of wringing our hands. But again, we can't really tell. You need to prevent bleeding. So it's, saving the patient is a live patient at the end of the day is far more important than what a pathologist is concerned about.
Okay, well, we just have a couple of minutes left. I'd love to open the floor to any questions. And I haven't looked. Oh, I see we have, so great to see so many people attending. And if you have any questions, if you can post them in the chat. Holly Mikhail, do you want to comment or on any of these cases? It's great to see you this morning.
It's great to see you, Prof, and it's great to see Mary Roberts. And we started this eco session again. I'm so excited, and thanks to you for organizing this and also having EUAs, having generous biopsies, and also saving lives of a patient who could be treated with cancer that are treatable like tuberculosis. And I don't think we have seen a case before. Maybe Taye could add on that, and very supportive Korea hospital too. So I'm so excited, Mary Roberts, for explaining all these cases. I hope the pathologist will also learn from this and how the clinician and the pathology approach such kind of cases. Yeah, I've never seen the pancreatic TB case before. If there is any prior exposure, Prof, and like as you said, it's empirical therapy is also important in such kind of patient. We see the response. I hope we see the response of the imaging, how it's resolved on the next after treatment. And are there any prior pancreatic TB reports? And when to start empiric therapy if we cannot send also for such advanced AUS therapies in procedures?
Yeah, well, I agree that it's rare. I've seen one other definite case of pancreatic TB. Actually, I saw it in Minnesota, not in Ethiopia. And it was a young man who he had come from India, working for a tech firm, very successful person. And when I asked him if he had been exposed to TB, he laughed at me. But it turned out that there was a family history of TB, and he presented with obstructive jaundice and a thickened bile duct wall and an adjacent pancreas mass, and it was TB. And there we were able to do cultures and PCR and prove it definitively. But it is rare, and I want to repeat, I don't think that every patient with a
Yes.
pancreas mass should be receiving TB therapy. Especially, many of them are jaundiced, and that TB therapy won't go well. So it's in this case, the appearance of the lymph nodes on contrast enhanced CT and the normal serum tumor markers were clues. And if you're in Ethiopia, anyway, you could send the patient to us in Addis. We will take a biopsy for you. And we have many people on the call working elsewhere in our region who have access to EUS. So, yeah. Mesfin, do you want to comment at all as another pathologist on the call today about any of the cases?
Thanks so much, Prof. It's really great to have Professor May, and very nice cases, very interesting cases, and insightful cases indeed. I have no experience with pancreatic TB. It's very interesting also to see that case with a crushing artifact. I think we can help at St. Paul's. We can do cytokeratin stay, and we can show that in the next session probably. So
Beautiful.
we can collaborate.
Yeah, collaboration.
Absolutely.
We'd like to have more cases also in the future.
Okay.
Yeah.
I will provide you the blocks, Dr. Mas.
Yeah.
Okay.
So we're out of time, so I think we're going to wrap things up, but it's great to see all of you. Professor Robert, thank you so much. This was so fun for us, fun for me to see you and to learn from you as always. And
Me too. I love this. Thank you.
So we'll look forward to the next time. So everyone, thank you. We'll look forward to seeing you at our next session, perhaps in a month or so. We'll be in touch. Have a good day, everyone.